So this is a subject that I care a fair amount about, and when I get excited, I talk faster and faster. So if I get to the point where I'm not easy to understand anymore, then just like wave your arms or say something, and then usually that will slow me down for a minute or two. Let me get my... I got interested in how to be sick well, and this is not going to be a lecture on how to be a good patient, which of course our parents told us all about before. And the last talk that I gave on the art of illness, I think there was a certain amount of high art in there and talks about creativity. This one is more low art. It's more like cooking, or I guess, well, maybe performance art, in the sense that like performance art or like bad performance art, there's a lot of undressed people and like unnecessary bodily fluids. But like great performance art, I think the art of being a patient can really, when I've seen patients do it well, it makes you realize how there's not that much barrier between living your life artfully as a work of art and just living, that they can become the same thing. But in terms of being practical, and I will try to be practical today, I'm going to talk about these obvious things that we all need to know when we're sick, which is how to get help, and then when you get it, how to deal with it, because often it's not exactly what you wanted. And then I think there's the I don't want to be a burden problem that a lot of people have when they're sick, how to minimize your effect on other people. And actually, I think it's often really possible to do them good too, and I hope I can convince you of that in a way that doesn't seem too idealistic. Because, you know, as a doctor, I've gotten an amazing amount of benefit from my patients in a lot of different ways. The problems with this, and I want to be very clear that no one should expect a sick person to be artful in any way. It's really not fair at all. The problem from the patient's point of view, though, is whether or not it's fair. If you don't do your job as a patient well, if you don't act artfully, you don't get treated like a patient. So if you go into an ER and say, I have a migraine, and you're speaking in a calm voice, and you say, I have 11 out of 10 pain, if people aren't convinced, they're not going to treat you as a patient. They'll just say, oh, you're med seeking, and make you wait for 16 hours and then discharge you. Another problem about this whole issue is that people are afraid to think about how they're performing as patients because they don't want to seem manipulative. They don't want to be seen as playing sick. And then the final big problem, I think, is where do you learn the art of being sick? Most of us learn it originally from our families, and that's fine if your family is really good at it, but people who come from, say, neglectful homes or homes with a lot of trauma or have had really difficult experiences end up with very unusual ideas of what it means to be sick. Like if your parents don't come unless you scream as if you're dying, you learn that that's how you should behave when you need help, and then that can just be very off-putting for clinicians who say, well, it's just a hangnail, dear, and think you're overreacting. And then of course there's TV and novels, and this is a pointer, I guess. For those of you who've seen Dr. House, you know the kind of models that you can get on TV are not always ideal. And then finally there's the web, and so I was interested in what you can learn from the web, and it turns out that it's just platitudes. I went to like some of the most popular and really the best sites. I didn't try to like lowball it, and you just find this junk. I mean, like, be honest, be on time, be patient. The stuff is either hard to follow or it's just wrong. Like, don't give up ever, ever, ever. There's lots of times when you should stop beating your head against the wall. So I got interested in this. Well, I'll tell you why I'm interested in particular in this question in a little bit, but then there's specific advice, and often it's just disease specific. So here's a little tip that all of you can use if you think you're having a heart attack, but it's very specific to heart problems, which is Levine's sign. And every med student learns that if a patient puts their chest over their fist over their left chest and says, I feel like there's an elephant standing, it's crushing, those words are like red flags, and everybody will do a rule out MRI protocol on you in the emergency room. Whereas if you say, oh, I think I'm having a heart attack, then it's going to be different. But this is, not general enough for most of us who don't have heart conditions. And so I was thinking if I was going to write about the art of illness, I wanted to find something that was useful generally, apply to a lot of different diseases, and also, if possible, work cross-culturally, because as the population gets more diverse, so much of what we think we're communicating, we're really not. So back to this question of the problems of acting, learning how to behave when you're sick. Doctors, of course, are very anxious about this idea of teaching patients how to act, because the first thing they think of is insurance fraud. Well, it turns out that fakers already have a lot of skills as actors. And in fact, one of the ways of telling a malingerer from, say, somebody with a psychosomatic condition is that the person with the psychosomatic condition who has, maybe subconscious emotional issues driving their sickness, they do a much worse job faking it than an actual faker. And so I'm not putting anybody at risk by teaching you how to act sick, because you already know it if you think you need to know it. Then there's a second worry that doctors have, this sort of a little knowledge is a dangerous thing, where don't read about your illness. A little knowledge is dangerous. That's totally false, as you know. The only thing worse than a little knowledge is no knowledge, which is even much more dangerous. So I'm actually, obviously I'm pro empowering patients by teaching them what's going on. And then there's the third worry that doctors have, which is whether empowering a patient to ask a lot of questions and so forth will slow them down. And there was actually a wonderful project by Margarita Alegria, who is at Cambridge Hospital, where she has this thing called the Right Question Project, where she took mostly immigrants and taught them how to act sick in America. What questions to ask, what they could expect. And at first the doctors were like, no, I don't want my patient to ask questions, And in fact, it turned out to be so helpful. The patients knew what they wanted. The appointments were actually much shorter because the patients could ask the right questions, that now doctors are referring their patients to these. So all of this is for any doctors in the audience. I feel like, I'm a race trader, that I'm giving away these techniques that doctors shouldn't be revealing, but this is my excuse. That being said, of course, it brings up this huge bias issue, right? Here I am, a doctor, telling you how to be a patient. Aren't I going to want you to be nice? Kind of, yes. I am also biased in another way, which is that I have been a patient a fair amount in my own life, and a very bad patient in a lot of ways. So I can use you as I'll use as a negative role model maybe, but also skilled, because being a doctor when you're a patient gives you a lot of advantages. But anyway, so I've tried on a couple of slides anyway to put a bias warning when one of these factors is coming out wrong. But just to give you a very brief overview of my experiences as a patient, a lot of them were while I was a medical resident. And over a pretty short period, I had like 6 different hospital admissions on different services for various things that ranged from being hit by a truck to having an acute abdominal thing that people thought was cancer at first. And then my family also got sick all through this same period. My husband had a punctured lung, and then that was repaired, and then he had a tension pneumothorax, which is the kind of thing that can kill you very quickly. I had a daughter with bacterial meningitis who nearly died, and so on. And so I'm mentioning that partly to point out something about the way I was telling that story, which is people who've had what they consider a lot of illnesses, they get kind of proud of it. Like, secretly, I want you to know how much I suffered. And you can smell that about a mile away in a lot of people telling their stories. And I want to mention that because, in fact, of course, I wasn't the winner in I'm the sickest, even among my friends. Another friend of mine who had 2 metastatic cancers before she was 40 and had 4 children under the age of 4 when she was diagnosed with the first one. Like, she was the winner in my friends. And we actually had a lot of fun in a weird way talking about different aspects of being ill. She was very concerned about not using her illness as a tool, and she made this great list. I should see what I'm actually supposed to be talking about. I'm going off on a tangent here, but she made a great list of things that cancer taught me. These were actually things she was trying to avoid, but I just thought they were pretty useful to know. Like, she said, well, you can speed with impunity, because if a cop does pull you over, you can just take off your wig and say, I'm racing to emergency chemo. So that was the kind of thing that she was tempted to do, but she never did. I did sometimes, not with the wig. But the other thing I want to say about this concern that we have about acting sick is that if you're trying to act natural, when you're sick, acting natural means acting like a baby. It means screaming your head off when you're in pain. And that's just not natural for adults. So very clearly, a lot of our illness behavior is innate. We don't need to learn how to cry. And even blind children can wince, even though they've never seen a wince, if they're born blind. So that's innate in a lot of ways. What we do need to learn is when not to cry. And the other aspect of just the power of a baby crying is that body language turns out to be a lot more powerful than words. And that's something that everyone underestimates in medicine, probably because all of our academic training gets us too word biased, And so we think that words are powerful when, in fact, actions and gestures and physical actions are much more so. I have so many tangents I want to go off on. I'll try and keep on the program for a little bit, though. So pain behavior is both innate and learned. As I mentioned before, like childhood neglect can really disrupt learning. I'm putting up these 4 faces. This is 4 of the, is it 6 or 7? I forget. Fundamental facial expressions that are universally recognized. And it turns out there's a whole lot of behaviors that really are cross-cultural. And I got interested in how so many of our basic nonverbal communication is shared with animals too. So on the left you can see the sort of classic non-aggression kowtow, which puppies will use when they want to play. It's like saying, I'm going to wrestle with you, but I don't really want to hurt you. And so the kowtow, of course, has also a long tradition in other cultures besides dog culture. And then on the right is the classic victory, arms above the head thing. Most recently, Amy Cuddy at the Harvard Business School has argued that if you do this for 2 minutes before a job interview, that you'll be like you're more likely to get the job. It increases, not only does it make you act more confidently, but you feel more confident. And that's even seen in lobsters. So everybody knows who's winning that fight, right? So what lobsters do is they just wave their claws until one of them decides, oh, that one's taller and bigger than me, and then they stop. Now, obviously, not all gestures are universal. And so we all know the stories about, the gestures you make in other countries, like the OK sign in US means screw off in Brazil. And the way to know what's not universal is if it would confuse a 3-year-old, it's not universal. Everything else is fair game. So here's maybe just a little question to start with. Obviously, it's not just body language, it's what we do with our bodies in space. It's many, many things. There's a question of when you're visiting a doctor, what's the best way to create a therapeutic alliance? How would you want to arrange your desks? How many votes for A? How many votes for B? I'm not going to give you a lot of time to think. Good. How many? Oops, now I've given away. C and D. So C, you'd think maybe that's good because people are on the same side of the desk, but it's actually quite invasive. If you don't know the doctor well, you don't want to be sitting right next to them. And D has the disadvantage of being confrontational, face-to-face, but there's not even a desk between you. You're right next to each other. So both of those are pretty stressful, especially for the patient.
Where's your computer?
Where's my computer? Oh, that is a very good and embarrassing question. So yes, actually, let me just mention that there's a big problem with body language nowadays, which is the doctor, if they're not looking at you and they're looking at the computer, you can just wave your arms and they'll never see it. So that's why both language and nonverbal communication it's a useful combination so that you can just say, look at me if you need to. But that's a huge problem. And but also I have to mention that a lot of doctors who are looking at the computer, it's because they're secretly shy. I mean, they're doing it because it's stressful for them too. And a lot of doctors, even who've gained the polish of appearing to be extroverts, they were all like pre-med weenies at one point in their life. So part of the reason I got interested, I'm basically a writer, and I always thought of literature as the art of medicine and everything, but I got interested in performance because I ended up getting involved in a couple of movies and TV productions that were very interesting because it turned out, as a doctor, I realized that, this one in particular was based on a book I wrote, and the woman on the right was supposed to be the me character, and so she was looking at videos of me on the web to incorporate some of my mannerisms, but what I realized was she actually had much better bedside manner than I did. When she was talking to patients, she was so much more, she had just ability to communicate. So I started imitating her as she was imitating me. And it was this sort of art imitating life, imitating art thing. Most recently, I've been involved in a sort of art video that's being made on standardized patients, the people who pretend to be patients to teach medical students. And I had fun. I was actually an actor in this, where I was a delirious patient in an emergency ward in like a really low-down New York hospital, which was very interesting to see and talk to the standardized patients, people who are professionally doing this, to see what they had picked up. There's a very good book by Leslie Jameson right now that's just released called The Empathy Exams, which talks about her experiences doing that. So let's talk about how to communicate distress, which is the first thing. When you want help, you have to look like you need it. There is, of course, this big spectrum that all of us think about in one term or another, which is, on the one hand, you have like the overstoic person who is like got a gaping chest wound but doesn't mention it. And then on the other hand, what you might call psychosomatic or hysterical, where somebody has what people would label as an imaginary illness. Now, I personally think that a lot of those, quote, imaginary illnesses are merely misdiagnosed. They're just not, they may be complaining of their liver, but it's something else. I think they are real illnesses, but the standard view of it is they're complaining of something that's not real. And so we all want to be like right in the appropriate range, but looking as if we're overstoic. So, of course, to be stoic, right, you have to be in pain. So no one's going to call you stoic unless they can see the pain just a little bit, right? So if you just look like you're not in pain, then they say you're healthy, right? No one says you're stoic. So you have to, it's a very difficult game to play. Game in the big sense, like not frivolous game, but. So good complaints are useful. And here's a piece of MD jargon that is often offensive to patients that I just want to clarify, which is that chief complaint, and doctors will use the word complaint a lot. They don't usually mean it in as derogatory a way as it sounds. They use it just to mean the reason for the visit. So they'll say the CC or the chief complaint. So when they say, what's your complaint? They don't mean like, how whiny are you? That being said, the overtones of like, it's offensive, and there is a sort of derogatory character to it that is a language fact that should be changed. So when is it useful to see a doctor? The first thing is to know what you want out of the visit. Here's where it gets to be platitudes. Like, of course, you need to know why you're going. But one of the the most fundamental distinctions that people sometimes confuse, I think, is do they want just a diagnosis, a label for what's going on? Do they want treatment and they don't care as much about what it is? There's obviously all sorts of ranges in between. But people do make a certain number of mistakes about this. I think the thing that I see the most often is that someone will come in with a pain and say, well, I don't really care about the pain. I just need to know what this is and make sure it's not a brain tumor. And that's what they think. I think they believe that most of the time. A few people are just prevaricating. But they will not be reassured about it's not being dangerous until you can get the pain to go away, because the pain is driving their concern, their worry. And so the common thing for a neurologist to do, me being a neurologist, is we say, oh, don't worry, we did the MRI, it's not a brain tumor. And then we send them out. We didn't even give them Tylenol, So they're going to be back in a couple of days because that pain is still driving them. It's still a signal saying there is something really wrong in your body and you need to fix it. So a doctor who takes a patient seriously who says, I don't care about the pain, may end up in one of these cycles. So think about why you want to know what it is and why, if you've had several tests already, why they haven't made you any more confident. And then another common one, of course, is anxiety presented as physical pain. The problem with that, like anxiety and depression, people always say, oh, you're just depressed, dear. It's real pain. These are, physical illnesses that actually do worsen the pain. It's just that you probably won't be able to solve it with NSAIDs or opiate, non-steroidal drugs or opiates. You're going to need maybe treatment of the anxiety or the depression. And then a third thing that's sort of a rhetorical issue when you're going to the doctor with your chief complaint is if you have too many complaints, the poor doctor, their little brain just gets overwhelmed. And especially if the too many complaints are all what we would call soft signs. So soft signs is like neurology jargon for things like my heart's racing, I feel dizzy, my vision is blurry, I'm sweaty, I'm dizzy, I'm nauseous. And what's actually true of all the soft signs is that, and I don't think people really point this out too much, but they're all products of the autonomic nervous system. And sorry if a lot of you probably already know this, but the autonomic nervous system is this very diffuse set of nerves and locations in the brain and spinal cord that control all the sort of vegetative functions, heart rate, blood pressure, sweating, adrenaline release, gut movement. And in one sense, the goal of this system is to keep the body in a steady state. So, it's partly to, one half of it is to help you escape from things. If there's a stress, it gets your heart rate going and so forth. And another half is to sort of take care of all the housekeeping functions like digestion and so forth. So all the soft signs I was mentioning, including pain and tingling, like skin fleeting pains and constipation, and especially things like rapid heart rate. When doctors hear that, at some level they think, oh, this is just from stress, this is just anxiety. These are just common symptoms of, like, say, too much adrenaline, because overactivity of the autonomic nervous system will do that. So if you come in with this list, people are going to be like, okay, what's the real complaint? What is it really? So let's talk a little bit more about, maybe I should stop. Does anybody have any questions? Because this is one of the ways to keep me from speeding up. So if you have a question, just raise your hand.
What was the last thing you just said? What's the real complaint?
Oh, I don't know. That's why I changed slides. Because it'll vary a lot from.
The answer to that?
Yeah, so it varies from person to person. For instance.
That's not the real complaint.
Yeah. So I can think of an example where the person's actual symptom was buried in all the other stuff. I think in that case maybe it was double vision. I'm kind of making that up. Yeah. But that can get overlooked if it's embedded in all the autonomic stuff. Now, autonomic symptoms can be sign of very serious disease, and so it's not like, even if all you have is autonomic dysfunction, that can be a disease. I don't mean to minimize it. For instance, there's tumors that cause too much adrenaline release and things like that. So how do you communicate pain? Here's some bias stuff, like, please avoid tangents when you're telling me this story, because it's like, I really don't need to know as a doctor that, well, it was when I was visiting my aunt, or no, actually it was 2 weeks before that. So it's hard for people when they're sick to really focus in on the important stuff, but your doctor will love you if you do. And then avoiding hyperbole, I'll talk a little bit more about that in a minute. And then non-verbally, so we all know about, wincing and groaning as signs of pain. Then there's the stuff that's not really possible to do voluntarily unless you're like a swami, which is changing your skin color to be pale, or sweating, things like that. Now, there's a problem with that which doctors often neglect, which is people who have chronic pain. A lot of these autonomic signs habituate, so their body has just given up getting pale when it's in pain, because it's in pain all the time. And then a final mistake, sometimes, or not mistake, but a confusion that people will make is tears. Tears are not a sign of pain or physical pain. They're a sign of emotional need. They often go together, and we get confused by infants who really have only one state, which is distress, right? And they don't make a distinction between pain and my mother isn't here. But in adults, crying is usually a sign of you feel neglected by the doctor, or your boyfriend just left you. And so somebody who is crying as they say, my side hurts, is sending a mixed message that the doctor may just see the tears and think, oh, it's not my problem. So when we talk about wincing and groaning, there's actually some interesting studies of looking like you're in pain that show that actually what's more effective than pain expressions is signs of pain suppression. And so they did a study where they had people who were in pain, I guess they were like pinching them, and then they would have them exaggerate those expressions, and they would have them try to suppress the expressions. And observers all judged the people who are suppressing as being in the most pain. And this also applies to other things besides pain, like exaggerated limping, where you're like holding your side. Like, there's actually no reason to hold the side except as a signal to say, I'm in pain. So all of those things are often interpreted by the observer as being like, they're just yanking my chain, it's not real, real in quotes. The thing about that, which I think I took out those slides, but pain behavior really is a sign, it's a type of communication, so it makes sense to show where it hurts. It's just that people start second guessing you. They're like, oh, he's trying to communicate something, this isn't real. But even monkeys will do that. They'll hold their stomach when their stomach hurts and so forth, because it helps. Monkeys will do that. Now I really am on a tangent. Monkeys will do that if they're monkeys that are in large social groups. If they're solitary monkeys, they don't have pain behavior, because all it does is say, eat me, to predators. It's only if they have friends and relatives that will help them if they have pain behavior that they develop it. So all pain behavior in that sense is communication, except for some things like limping where you really are trying not to damage the injured limb. Anyway, enough about faces. So what are some alternatives to complaining about pain? As I mentioned, showing pain suppression, and that's like, it's actually not pursing your lip together. I think that also counts as like fake suppression. What people do is actually part their lips just a little bit. They're sort of trying to like not have an expression. But then the second thing is get someone else to complain for you. This is incredibly powerful. And I've seen people say, oh, didn't want to bring my girlfriend, like partly, I don't know if they thought it would be infantilizing because she'd be like, oh, he's suffering so much. That's really effective. If you have somebody in your family that will say how much you're suffering, then you get to look stoic. You can be like, oh, it's not so bad. And then your spouse is like, but don't you remember the time when you passed out in Kmart? So there's all sorts of other reasons why if you have a family or a friend or even just somebody you hire off the street, bring them with you. Because then you're going to outnumber the doctor and bodies count. It's all a very primitive thing, but I pay more attention to people when there's a couple of them in the room, and they can take notes for you, and they can, if you feel faint on the way home, they can help you. So a bigger aspect of this, and I apologize for my kind of snotty tone, but this is also a very serious point because pain really is something that brings people together, and I'll talk a little bit more about that. But you're forming bonds with the person that you come with, and anyway. So the thing about the jokiness, there's a medical name for that, Witzelsucht. It's like inappropriate humorousness, and it comes from damage to the inferior frontal lobes. So that's what I have. I make jokes about things that are important. Oh, Witzelsucht, it's like German for inappropriate jokiness. And they like to give like disease names for every kind of behavior, and it's usually from damage to the inferior frontal lobes. But sometimes it's better, you'd rather laugh at something than cry at it, and so people then do tend to be inappropriately humorous about illness. So a third thing about, instead of just saying, oh, it hurts, is pain scales. And I don't know who invented this idea, but it's very popular now. This was actually one that was based on like what's a scale of how big the thing is that's sticking into you. Someone developed an insect sting. It was an entomologist, so it was like different bugs and how much they hurt, and he tried that wasn't very generalizable because some of the bugs were really rare. But the standard one that everyone uses in the clinic is to say, is it a scale of 10, if 10's unbearable pain and 0 is no pain, and then they ask you. So the first the most concrete advice I can give you is never say you have 10 out of 10 pain. Because the problem is the doctor never really tells you enough about the scale, but 10, the worst pain imaginable, you're not going to be speaking, you're not going to be moving. You can't say I have 10 out of 10 pain. It's like it's a oxymoron or a contradiction in terms. And never say 11 out of 10, which we hear a lot of. And then you say it's as bad as the pain can be. It just makes the doctor want to just like yank the arm and say, look, it could get worse. So it wasn't 11 out of 10. I'm sorry, this is not appropriate. So this is my like doctor bias coming out. So what's really useful, at least for me, and I think for a lot of doctors, is to quantify your pain by its behavioral effect. What does it keep you from doing? And so here you have all the activities of daily living. Like it used to be that I could go to work with this pain, but now I can't get out of bed. That sort of thing is very helpful for them to calibrate how bad it is. It works a lot better within a person than across people, of course. But that's the problem, that when you try to compare people, somebody who's a stoic, they may still be going to work with pain that I would be at home, whimpering with. And treatment is really unpleasant. I think all of us know that. Even when it's pleasant, it's still kind of unpleasant because you feel like you're infantilized, you're sick and powerless, and then you might feel guilty about being a burden. And then often the patient knows their body best, and they have to pretend that they don't, or the doctor will get all huffy. There are some cases where you don't know your body best, and that's especially true when it's a new illness, when you've never had these symptoms before. Then usually people are willing to take advice about it. But if you've lived with it for 10 years, you're right to believe that you probably do know more in a lot of ways than the doctor. What was my bias here? I forget. I probably have so many biases on all these pages. I think it was just that you can tell me what my bias is later. So this is I wanted to show this video, which is pretty funny, but I think it's also quite illuminating, and I'll just let it run and you can decide.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless, and I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like... There's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way.
Okay. So what point was I trying to make with that? I think it's obvious that treaters who want to help a lot can see their patients as behaving like that, and sometimes the patient really does just want to tell you about it. Most of the time they want to be helped, but not in the way the treater wants to help them. So maybe if she had like non-snagging sweaters, that would be enough for her. She doesn't want the nail taken out for whatever reason. Maybe he could explore that. So I mention that partly because you'll see your doctor getting frustrated when you come in with your headache and they say, well, you should try this medicine. You're like, well, no, I don't like medicines. And, oh, well, we can send you to a surgeon. No, I don't want surgery. Then they get anxious because they want to do something. They're very action oriented. And there are ways that you can, I mean, if you know it is what it is that you want, if you think about it, you can tell them, no, this is what I want. I want a note that I can get out of school or whatever it is that you need. If you make it explicit, then they can feel like, oh, they're at least doing that for you. But the other thing is all of us are also caregivers. Even if you're not a doctor, you have family members that are doing this to you. And so I think seeing both sides of that hysterically funny video is useful. But let's say you do decide to take your doctor's recommendation of trying some medical therapy. How can you best do that? And probably the simplest and most common mistake that people make, and I've done this too, is, as a patient, that the trial has to be a reasonable length. Now, I'm obviously not, if there's something life-threatening like your heart stops, then yes, you should probably discontinue the medicine after one dose. But more often what happens, people will jump to conclusions. The day that they take the medicine, they feel nauseous, and so they stop it. And there's a couple reasons why that could happen. One, I especially see it with smart people, that in general, smart people will jump to conclusions about patterns that they see in their illness, and they're always looking for connections, and so they'll overgeneralize. But it's a very easy generalization to make. Of course, I took a pill and then I felt sick, so this is not the pill for me. Naturally, you want to have the scientific method, which really is sort of a beautiful thing. Avoid confounding variables. If you just broke up with your girlfriend on the day that you started the pill and you felt horrible, it might not be the pill. And all this sounds very obvious. Of course, in practice, it's hard to keep track of all those variables. And that's where, a friend or a doctor can be kind of an objective person that you can work with. You both have different approaches to it. So if you can, think of yourself as a co-investigator with your doctor rather than them just shoving pills down your throat. And of course, you have to find a doctor who's willing to do that rather than just shove pills down your throat. Another problem with trial length is tolerance and habituation to medicines. I'll talk about that in a minute. But then there's the big issue of people who are very sensitive to meds. And this is a phrase that makes doctors shudder for a couple reasons. One is, that's what we do, we give you pills, and if you don't want our pills, we feel like powerless, and then we don't know what to do. But there's a couple of reasons why people are very sensitive to meds. a lot of people, some of them just need low doses. Like they get a nice robust response, but they only need 15 milligrams instead of 100. But there's also people who are very anxious about pills, and they'll overreact to even the slightest sign of a side effect, and that's what they mean by sensitive to meds. There's ways that you can get around that, and that's an awful position to be in. Everything you try is just making you sick, and I'll talk about this in a minute. And also, a lot of times when meds are triggering these soft signs like dizziness or nausea, it can even be your anxiety about the pill rather than the pill itself. One way to prevent this, like again, all these are sort of primitive solutions, but often they'll be helpful, is start with a really, really small dose of the meds, so small that any side effect that you feel is from your body's anxiety about the pill rather than the pill itself. Go up slowly, and your body will often be able to tolerate a medicine that you couldn't. That takes a lot of trust between the patient and the doctor, and that's often hard to achieve. But I wanted to talk about a really big and important issue that I hope isn't too overfamiliar to everybody. So medications, a lot of medicines you get either tolerant to them, either their effects or their side effects or both. And a lot of this has to do with the autonomic nervous system too. The body is trying to maintain a steady state of things like arousal, so it doesn't want to be too sleepy and it doesn't want to be too awake, and even things like pain. So the body expects a certain level of pain, and if there's not enough of it, it thinks, oh, I'm missing something, so it will lower the pain threshold until you get some pain. And so when you take a pill, let's say a stimulant, or how about a sleeping pill, your body has some idea, rightly or wrongly, of how awake it thinks you should be. And if you're too sleepy, it starts gearing up all the stimulant systems in the body to make you more awake. And this usually takes days, and depending on the pill, it could be weeks or even months. But the body tries to bring you back up to a level of arousal that you had before. And what this means is that over time, the medication effects are being counteracted by your own body fighting the pill. There's some pills that are much, much more susceptible to this, and especially sleeping pills, opiates, and stimulants are the biggest. What that means is that you won't get the same amount of benefit, and so people will increase the medicine. For some pills, it doesn't end up, you don't completely counteract the effect of the pill, and so you're still getting benefit even though part of your body is fighting it. And sometimes there'll be side effects that will initially be very prominent, and then your body overcomes them, like constipation. Your body may just gear up its bowel movement, the movement of its bowels. And often these don't happen at the same rate, because if you get rid of the med benefit and the side effect at the exact same rate, then you end up kind of with nothing. So the problem with that is, though, the pharmaceutical industry has made billions of dollars out of pills that end up giving you nothing if they initially have an effect. And so I'm just going to give like the little sleeping pill speech that you've probably heard before. Every sleeping pill on the market has habituation enough that after chronic use, you don't get any more benefit from it. So you're taking it every night and you're sleeping just as badly as you did before. There was maybe that glorious first couple of days or even months where you were sleeping better, but you end up the same. And you say, well, this sucks, I'm going to stop it. Then you stop it and you get rebound. So rebound is the flip side of this. Your body has geared up, it's got all its stimulant systems going to keep you awake to counteract the Ambien or whatever you're taking. Then you take away the Ambien and it's like spinning its wheels. It's got you all jacked up and there's no longer the sedative to fight that. So you stop the pill and then you're sleeping even worse. And you're saying, oh my God, I did need it after all. And you restart it. And the pharmacies, the pharmaceutical company makes billions selling you these drugs that you think work simply because you're getting rebound when you stop them. So I'm being a little cynical. Not all drugs have this problem. Some drugs you just never habituate to, but it's something to keep in mind. So I think we all know that the placebo effect is when you give somebody a pill or any kind of treatment or even just reassurance and they expect it to work and they'll feel better. They perceive, so you give someone a sugar pill and you tell them it's morphine and they're like, wow, that really helped for a while. That's not just like stupid people or susceptible people. Most people have placebo effects, and in fact, smart people are more likely to have them than like super stupid people, because the reason is you have to be smart enough to have an expectation of something working. And it's a basic function of our brains to anticipate what comes next and kind of prepare us to do that. So that the byproduct of this is that our expectations very much influence our experience. But it's only for a while. Your brain catches on after a while that, oh, it's just a sugar pill, and the placebo effect wears off. Now, this is a very real phenomenon. It's by real, I mean, like chemicals. That's the current definition of real in this talk. In that, for instance, placebo pain effects are generated by your body's endorphin release. So endorphins are like your endogenous opiates that are in your body. So if I tell you that this is morphine and you feel better, I can block that effect if I also give you a opiate blocker like naltrexone. If I give you that at the same time, you're not going to feel any placebo effect at all because of this opiate blocker that I gave you along with your sugar pill. So it's a brain thing. And there's lots of very interesting aspects to that. But what I wanted to mention, what you so cleverly asked, is the nocebo effect, which is way more of a problem, I think, in a lot of people with chronic illness, which is, it's like the no part is giving it away. It's when you expect something bad to happen and then you experience it. So I give you a pain and say, oh, this is really going to help you, but I give you a pill and say this is really going to help you, but the last 10 doctors have also said that, and then the thing made you sick. Even if it's morphine, you won't get a pain benefit. And again, you can do this with like just sort of average people. You don't have to be nuts for this to happen. You just have to have had a lot of bad experiences with meds. So again, the nocebo effect will go away after time, and sometimes a patient who's failed a lot of medicines, but you finally get them on the right med, and if you convince them to stay on it long enough, finally their expectation will catch up with reality, and then it can help them. But if you've had a lot of bad experiences with meds, you're probably going to have, at least for a short time, a bad experience with the next one. And it's hard to combat. Like, I know all about the placebo effect, right? Every time I drink coffee in the morning, the first sip that hits my lip, and I know that the caffeine hasn't gotten to my brain yet, I feel so much more awake. Because some primitive area of my brain is like, yippee, here comes the caffeine, and it gets me all geared up. And I consider myself, very sensible. And let's see. In terms of treatment, I think there's been a lot of well-intentioned push to having prevention of disease rather than treatment. And I just want to say one cynical thing about a lot of the medical screening tests that have been aimed at preventing illness, like by screening for PSA or doing frequent colonoscopies. A lot of them are just total BS. They don't actually catch a lot of diseases. They just give you a lot of tests and side effects from tests. But there is, of course, a lot of evidence that you can prevent illness with lifestyle changes. And I stuck Charles Atlas up there because that's like kind of what we imagine lifestyle changes have to involve. Like you get super fit and then you're not going to get lung cancer or strokes or anything. So it's a hard process. But there's also a question of what health risks do we want to preserve? And there are some things that are still worth it. Like for me, the classic thing is somebody who's clumsy, like with Parkinson's disease, who still wants to use their table saw. So, I could say as a doctor, don't do that anymore. You're going to cut your fingers off. But it seems to me that if they want to, if building things is important to them and they're aware of the risk, then they should totally be allowed to go ahead with that. It's not like driving where it's going to hurt other people even more than it will hurt them. But then we get to the changing health habits, which of course is really hard. I'm going to have to speed up here. But of course this is important, so I won't speed up. It's a lot easier to change your environment than changing willpower. We all have this idea that willpower is a useful and powerful thing in our bodies, and there's many studies showing just how weak it is. And it's a physical thing too. In fact, there's some really interesting studies showing that willpower is very dependent on your blood glucose, and that when you make a difficult decision or when you exercise your will, you lower your blood glucose because your brain is burning it up. The brain's the biggest consumer of glucose. So it's a limited resource, so you want to kind of use it sparingly. And a couple of ways to get around having to use willpower every time you're doing something healthy. One is actually imitative learning, which if I have a chance I'll talk more about. And that's, if there are a lot of other people doing it, your body is we're all actually wired to imitate in good ways as well as bad. So an aerobics class is a lot easier to get moving than if you're just like doing jumping jacks in your solitary cell. Then besides imitation, things like immediate feedback, whether it's a coach encouraging you or a little text message. There's a lot now on like text message coaching where your healthcare provider, calls you up and says, "Oh, so proud of you for taking your pill today," and that kind of thing, which really do influence behavior. And then finally, there's habit, which we think of habit as being so, bad, but habits are incredible energy savers. And so if you're in the habit of exercising, you do it every morning at the same time when you get up, it's much, much easier than if you have to make a decision to go to the gym every day. And one way that you can make things, like, again, minimizing judgments, is if you have very bright lines, like, say, somebody who's given up alcohol and they say, "I can't have anything to drink." It's a lot easier than saying, "Well, I can have one drink, but like, what's the difference between 1 and 2? So that kind of sometimes very artificial bright line between what you can do and what you can't do can make things easier, even if it seems restrictive. I'm just going to give a pitch for exercise desks. I know I'm going a little bit off on a tangent here, but when you think about, I want to exercise to get healthy, it's hard, right? So we have this idea, like maybe 30 minutes of moderate exercise. It turns out that, especially for people who are already pretty fit, it may actually be better to do an intense set of intervals, like 2 minutes at top speed, three 2-minute intervals with rests in between. But then on the other end of the spectrum, it turns out that rather than that moderate 30 minutes of exercise, constant low-level movement may be much more effective in terms of like building stamina and losing weight and so forth. Because there's evidence that people who exercise for 30 minutes then actually tend to be less active the rest of the day. It's that homeostatic, that's the steady state thing that your body's like, okay, that's enough, I'm going to minimize what I do for the rest of the day. So people who fidget, who are always getting up out of their desks, they tend to maintain their weight simply because they're just doing a little bit all the time. And this is where treadmill desks are really helpful for people who are busy and work at a desk, and they can just burn shitloads of calories and help their health while they're doing their work. And it doesn't even take a big office, because you can get one of these little weenie things, which is the version I have in my office. And you can get treadmills on Craigslist for like $50, and you just saw off the top and stick it under a bar height table, and it won't cost you much at all. I'll talk if anyone wants to talk more. They're great. Chronic pain. So we mentioned a few of these things, that autonomic signs, the fact that you're going to have nocebo effect, you've habituated to all your pain medicines, and then chronic pain is depressing, and depression worsens pain, and so forth. And then there's this final issue, and I think it's an issue for people with acute problems too, is that doctors are much more happy if they think your problem is treatable. And what if your problem is not treatable, or if it's only a little bit treatable? What can you do? One thing that usually backfires is to hide your previous treatment failures. So I'll get people who come in with a problem that they've had for many years, and they don't have any records with them. And they don't want to tell me what happened with the previous 8 treaters, because they don't want to depress me and make me realize that everything has already been done. They want me to think in a fresh way. And sometimes it's useful to think in a fresh way. But usually what happens is I call up the old treaters and I get the records. Or if you don't, you're repeating tests that have already been done. So hiding previous failures is not a good idea. But actually what turns out to be hugely powerful, and I was really surprised, is just even showing gratitude for effort, for the doctor's effort, or for small gains, totally makes the doctor feel like, I can do something for this patient. I remember the first time it hit me was a patient who had chronic headaches, and I was like resident, I think, and she called up, she's like, I have this awful headache, and I said, well, have you tried Tylenol? And she said, no, I didn't try any Tylenol today. And then later she called back and said, I felt so much better after I took that Tylenol. And don't laugh, but I was like so moved. Like I felt like, I've really done something for that person. And so I was much more attentive from then on, because I felt good about myself. So you can really yank doctors change that way. But again, the final problem with chronic pain and with anyone who's really sick is it's just really hard to act well when you're suffering. So one thing that's sort of interesting, though, is concentrating on acting, on how you're going to best communicate with people. That can actually take your mind off the suffering. And so it can be helpful to think about how to communicate how sick you are when you're sick. And writers even use this technique. They're writing about how depressed they are, because writing about their depression is way better than just being depressed. They have a project. And then finally, acting in any way, acting healthy and thinking about sort of practical issues can make you feel healthier in a way that is kind of interesting. I've been kind of blurring action and feeling and not making too much of a distinction between it, because it seems like in our bodies, mental states and motor behavior really shape each other. So that Here's a great experiment that they did. They had people watch either sad movies or funny movies holding a pencil between their teeth so they couldn't frown, or across between their lips so they couldn't smile. And if you couldn't frown, you couldn't be sad in a sad movie. It was much harder. And the same thing was true if you couldn't smile. You didn't laugh, you didn't think the jokes were very funny. They've even studied people who've had Botox, which tends to lessen facial expressions. And Botox decreases their emotional experience a little bit because their body isn't having that action. So the bottom line is there's a lot of physical evidence for acting as if. So if you act as if you're healthy, you're more likely to feel healthy, and so forth. And so if the way you're acting is you're acting about communicating your illness rather than just acting in a sick way, you may feel better. And then the last bit of this talk, which I will probably have to shorten, is that the art of illness really is an ensemble performance. Like, doctors like to think that they're giving a monologue and you're like the patient audience that has to listen to it. But it's a group performance, and one of the things that mediates that physically is something called the mirror neuron system, in which there's brain areas that are basically, they wire us in a relatively primitive way to imitate other people's behaviors, and that includes facial expressions. And it turns out that imitation, as I said, if I smile, then I start feeling happier. If you smile, and that makes me sort of smile because of this imitation system, then I feel happier. And that turns out to underlie a lot of empathy, also the imitative learning that I mentioned. And although I don't want to sound too reductionist by saying, like, oh, it's all hardwired, it's something that even infants can do. This is like an infant imitating a completely unrelated graduate student. And so you don't need a whole lot of higher cognitive ability to do this. But at the same time, it's very, very much influenced by experience. And events can rapidly change it, which I mentioned because with doctors, there's always this question of, can you learn empathy? And you totally can, because you know what? I was so unempathetic before I went to medical school. Most people lose their empathy in med school. They come in very idealistic and then they get kind of burnt out. My empathy was so low, it had nowhere to go but up. But I learned it, and so I feel like I'm one of the people that have learned to be more empathetic. And they did a great study of people who were playing a game with somebody else that they thought was, they thought it was a real person. It was actually a computer. Where they either got cheated or they didn't get cheated by this opponent. And then they saw the person they thought was their opponent get a painful electric shock. And this was all done while they were in the scanner and their brain area could be observed. And so if you saw somebody who you thought played fairly get a shock, all your empathy areas in your brain lit up as you'd expect. If you had the understanding that they had cheated you, there was much less activity. And so this would happen, over the course of a minute or two. That information was enough to change what we think of as a very hardwired system, because it's both wired into your brain and also very influenced by the environment. I wanted to talk about this because there's a lot of emphasis on doctors' empathy for their patients and how important that is, but it works both ways, and you can use it as a patient to change your doctor's behavior just as they're trying to change yours. And so not necessarily, you don't have to feel their pain, but you have to look like you're feeling their pain, and you can get them to feel that you're in tune with them. But there's an issue, which is that if you're mirroring an emotion, there's always a worry, like if it's a negative emotion, aren't you just they're going to mirror you mirror their emotion, and then they see you're upset and they get more upset, and you get this kind of reverberating mirror thing. That's kind of why moms aren't great psychotherapists. They are so connected with you that if you tell them about some minor pain, they're like, oh my God. And then you feel really upset, and you've upset your mother, and it all spirals out. So if you're going to be mirroring, and this obviously applies to bosses and your children and stuff, not just doctor-patient relations, mirror negative emotions dimly, but do mirror them, because it turns out that it's much better to, let's say, if you have an anxious patient, this is where the study was done, to mirror their anxiety when you're giving them good news will actually help them feel more reassured. So if I say to you, oh, don't worry, your headache is not from a brain tumor, the MRI was fine, in a chipper kind of way, and they're very anxious about it, it's like you didn't take them seriously. But if you say, the MRI results came back and they were actually fine, in a worried sort of way, they take it as concern. It's like you get how important it is, and it turns out to be more reassuring. Again, you don't want to mirror back at the same level that they're doing it, or it will escalate. And you have to express their emotion. So if they're totally mad at you, you don't say, I'm mad at you too. You say, you must hate this place, you know, and you have a little bit of their vibration, but you're expressing their emotion. And it's amazing how effective this is. I was first told this, like how to deal with schizophrenics, angry schizophrenics in the emergency room, and it so works for everybody. And then once you've got them, you're sort of vibrating on their frequency, then you can start to change your, like, you know, oh yeah, the results were negative, and then you can start to relax your face and go from like anxious to sort of neutral, and then by the end, ideally, they're mirroring you back, and as you get happier and more relaxed, they do too. And there's a great paper, there's a couple of great papers if anyone's interested in reading this more about how politicians use this and therapists use it dealing with very impaired children. It's like a very powerful, and like the dog trainer, it's the dog whisperer guy, uses this technique with his dogs. Like you can't calm down an angry, upset dog if you're like, it's not so bad, like in a calm voice. You have to be kind of vibrating at their frequency before you can get them to calm down. So one of the things people look for in doctors is empathy. It's definitely not the only thing. And in fact, most people, although they say they want an empathetic doctor, will then tend to choose the one with like the bigger credentials first. So is there necessarily an opposition? Well, there kind of is, because somebody who's got a great reputation, they don't have to be empathetic anymore. They don't have to spend a lot of time with you. They know they can just whiz through because they have other things to do. So there's a little bit of a trade-off there. And if you're thinking about empathy, you want to look for shared traits because similarity breeds it. But then finally, and this is totally my own invention, but I want you to try it out. You can use the nose rub test. So it turns out that empathetic people will imitate your behaviors whether or not they're emotional. And so if you just talk to people and like, if you're interviewing a doctor and you just kind of rub your nose every couple of seconds, if they do it too, they're more likely to be empathetic, studies have shown. So I also thought we could do this with our residents, like when we're interviewing people for residencies, because you can't ask them, oh, are you empathetic? They're like, oh, yes, I'm so empathetic, and I volunteer at the local homeless shelter. You just rub your nose. So I wanted to end on this sort of back and forth interaction, because I forgot to talk about this when I was talking about that study where people were not empathetic to the cheater. It's related to what looks like there's a very innate drive for reciprocity. So when people have done us wrong, we want them to get shocked. It's kind of innate. But the other thing is true too. So when people have done us something, a really good deed, we feel incredibly grateful for them. And like I said, I was surprised at how powerful this was. Like I probably had never done anything nice for anybody before medical school, so it was sort of surprising to me that gratitude was such a powerful thing. And I also found it, like when I was sick and there were doctors that had helped me, I realized how painful gratitude can be when you feel like you can't repay someone for all the good things that they've done for you. And there's actually anthropologists who study gift cultures. I hope this doesn't sound too highbrow, but it's really relevant. There's a concept in a lot of cultures that don't have a barter system or a market economy, but exchange freely given gifts of a toxic gift. So if you give someone a gift that they can't repay, it's seen as toxic because it eats away at them. Like they feel awful. They want to help you back and they can't because they're too poor or whatever. And let's just see who is paging me. Oh. Throw that away. See, this is how empathetic I am. No, it's actually my family. That makes it even better, right? So the concept of the toxic gift was a problem for me with, in particular, one doctor that I felt like there was nothing I could do that would ever repay them. But it's also a problem when you're a family caregiver. So the classic example is the mother who won't accept aid from her children because she doesn't want to be a burden, for example. That's kind of like giving them the toxic gift. She's raised them, she's done all these wonderful things for them, they love her, and she won't let them help her back. And that is really painful. So all of you who are moms that are like that, like I don't want to be a burden, just think about it. In a lot of situations, your family actually will feel good if they're allowed to help you. And a great book on gifts, which is by this guy, Lewis Hyde, who's actually he's a poet, but he got very interested in the sort of idea of gift cultures. And one of the things he wrote about was, what is the art of medicine as opposed to the science of medicine and the part that you get paid for and so forth. And it really was the part that's the gift, that the doctor didn't have to do for you, like maybe they didn't have to spend the extra half hour with you. And that's the part that's so moving and so, and can, create this bond that for me has been the most really wonderful part of being a doctor. And so anyway, to get back to the story of that doctor that helped me, and I just felt awful, and then she moved away and I couldn't do anything to help her back. And then I was telling a friend who's a psychiatrist about, this was when I was a resident, he would always pay for lunch. And I'm like, I feel guilty, He's like, no, because when you're old, you can take out some resident and you can pay for their lunch and you'll be paying it forward. This idea of gift change that's very important in gift cultures as well. So I was like, oh, that's so cool. And then about a couple months later, I had an early appointment with a doctor, and when I came in, he was actually lying on the floor looking really bad, like gray and sweaty, and his pulse was high, and I'm like, are you okay? And he's like, oh, I'm just having I'm just feeling faint, I'm having a vagal reaction, it's probably something I ate. I'm like, well, you kind of look like stink, And he's like, no, I'm fine, because this is like doctors have such bad internal abilities to see their own illnesses. And it turned out he'd sent away his previous patient, and he was just he'd been lying on the floor for 45 minutes. And so I sat down with him and I got him like orange juice, how when you don't know what to do, you get someone a drink of water or whatever. And I stayed with him for like 20 minutes convincing him, yes, we really should call the EMTs. No, this is not, every time he tried to sit up, he'd get paler and sweatier. Finally got him off to the hospital, and he was in a new atrial fibrillation. It was very easy to convert him out of it, and everybody lived happily ever after. And I felt great. And it wasn't just because he'd helped me as well, but I'd finally sort of paid it forward to that other doctor. And so that was just a wonderful experience for me. And when there are awful, awful things about being sick, but the fact that it can make people feel connected in that way, I just think it's a great thing about medicine, and that's the end of my talk.
Thank you so much. I've had too much experience in all this stuff, but the last time I was hospitalized, I knew what I had, and it's like before I told the doctors, I said, I have pneumonia. I know it because I have a fever of 102, I feel achy, but I was so hyper-articulate, and it was because I also had low blood pressure. And it was like, if I get really hyper-articulate, they're going to put me in a psych. So, but what I really wanted to say, there was one omission, and that is you can get as mad as you want at a doctor because they get paid a lot, never piss off a nurse.
Well, there's
because they're going to do it all, they put it in.
Yeah.
They do the heavy lifting. And if they piss you off, they won't for you grab crackers.
Yeah.
Never get ice cream. And forget it.
Those are both such good points. I just want to pause a little bit on the like that issue. When you actually do know more than the doctor, how do you get them to not be intimidated or pissed off or like overreact? And that's a difficult skill. And then the nurse.
All in a group, and they were all looking at you and said, "This is what you're going to do."
Yeah. Right.
They looked at each other and they said, "Well, I guess we're going to do that."
Yeah. I know one woman who's incredibly good at making the doctor think they came up with that idea. It's hard, and she's like got the most sort of social intelligence of anyone I know. But you reminded me, I forgot, I didn't even get to the end of my talk because I have like the summary, they're all truisms and stuff like, willpower is a scarce resource. But I wanted to leave you with some concrete things, and one of them is just what you brought up, which is, these are all things that, they're not really fair, but the things that'll like make doctors in the ER treat you badly. And number 8, appear to have read too much. Like if you know more than your doctor, it gets them upset. And so that's totally unfair.
But if you're ill,
if you're
chronic illness and you've had it for 20 years.
Yeah. So in fact, that reminds me of a great story. I took care of William Styron, and this is not a HIPAA violation. He was fine with me talking about it, and he and his wife were very open about their illness. So this is the author of the Sophie's Choice. So at one point I was reading one of his he was admitted for depression, and this resident had written in the notes, thinks he knows more about depression than his doctors do, in this really snarky tone. So this is a guy who wrote a book about, like almost the book about depression, called Darkness Visible, who who actually did know a lot more about that his illness than the resident. It was just so funny. But it was also so clear that the resident felt really threatened by this guy. So these are all things that you shouldn't do. I'll email the list to anyone who wants it. You can cut it out. It's like wallet sized. Keep it in your wallet in case you're in the emergency room. So don't say 10 out of 10 pain. And I forgot to mention, don't say, I have a really high pain threshold, especially if you say that right after you screamed when they pulled the Band-Aid off, because it's like showing how, but seriously, it shows that you're defensive about it. Like people have already said, I bet that doesn't really hurt so much, that you're having to justify it. The soft symptoms, what else? Volitional symptoms, things that look voluntary are just, it gets people, as soon as people don't know what's going on, the doctor doesn't know, they want to blame it on you. Like it can't be that I don't know how to make you better, like I'm a good doctor, so you must really want to be sick. And so if they see anything that looks voluntary, that's a hard problem I don't have an answer for. Weird med symptoms, like saying I'm never sensitive to meds. What else? Not being grateful to your doctors, it makes them so unhappy. And I think we've already pretty much done all this, except don't come to the ER with symptoms that have already gone away. That's me just bitching. This is my doctor bias. Okay, I'm supposed to be taking questions.